Добрий вечір всім, хто до нас приєднався. Ми дуже вам дякуємо, що ви в вечірні часи до нас приєднуєтесь. І дві організаційних важливих речі. На прошлому вебінарі ми бачили, що ви пишете нам про сертифікати. Де ж наші сертифікати? Сертифікати не приходять сьогодні на завтра, тому треба просто почекати, і вони обов'язково будуть. Сертифікати будуть для тих, хто в Zoom дивиться всю версію цього вебінару прямо в онлайні наживо, і для всіх тих, хто зареєстрований в Zoom і залишив свою коректну електронну пошту і своє ім'я і фамілію, так, щоб ми могли їх внести в ім'я та прізвище, так, щоб ми могли їх внести в сертифікати. Багато з вас питає, де є записи. Записи є на каналі доктор Булавінова. Ми дамо посилання на цей канал в коменти до цього зуму. І ще будемо вам окремо робити розсилку з усіма відео, які вже є, як англійською мовою, так і українською мовою. Мене звати Катерина Булавінова, я медична експертка UNICEF в Україні. І цей проект ми робимо разом з пані Оксаною Збітнєвою та пані Іриною Микичак, тобто разом з координаційним центром Кабміну, який займається програмою ТИЯК, і також разом з Міністерством охорони здоров'я. Ми завдячуємо цій програмі професору Йоргу Фегерту, бо тільки завдяки йому ми маємо можливість мати професорів високого дуже рівня, європейських, які для нас в вечірні часи, в свій вільний час читають ці лекції. Ми їм дуже-дуже за це вдячні. Тому прошу Йорга Фегерта відкрити далі нашу сьогоднішню зустріч.
Thank you very much, Kateryna. It's a pleasure to open the meeting and to welcome more than 440 participants at that moment this evening. And it's a special pleasure for me to present Professor Benedetto Vitiello. He is both a pediatrician and a psychiatrist, and he worked for a long time in the US at the National Institute of Mental Health, where he was the head of the Child and Adolescent Treatment and Preventive Intervention Research branch. And all these huge intervention studies with multiple interventions, combined interventions, psychotherapy and medication, like the TED study in depression, for example, were organized by him and influenced very much all our treatment guidelines. When he retired from his work in US, he came back to Italy and worked at the University of Turin as head of Department of Child and Adolescent Neuropsychiatry, because in Italy, child neurology and child psychiatry are still combined, and you are an expert in both of the fields. And at the same time, he still is an adjunct professor at Johns Hopkins School of Psychiatry in the US. I hope that's all correct, Ben. We are very, very glad that you agreed to give us your presentation on pharmacotherapy of anxiety and mood disorders in children and adolescents. And the floor is yours, Ben. Thank you for being with us.
Thank you, Jörg, for your kind words, and thank you for the invitation. And thank to all of you to be here and to be interested in this topic. I hope that we can have interaction and I can have questions from you because I'm very much interested in your perspective on how to manage anxiety and mood disorders in children and adolescents. The focus is on medications, but I always keep in mind that medications are just an option, one of the possible treatment choices that we have when we manage these disorders. And so I will make some observations and comments also on non-pharmacological treatments. Okay, when we talk about anxiety disorder first, we are talking about a category of conditions that are very prevalent in children and in adolescents. All the epidemiological studies across the world have shown that anxiety disorders are the most prevalent, the most common conditions, mental health disorders in children and also in adolescents. So they are important because they're so common. Are also important because anxiety disorders oftentimes are a precursor, meaning they come before mood disorders. So one path to depression in adolescence is through anxiety. So there are children who, when they're young, preschoolers, and then in school age, they suffer from anxiety that is chronic, recurrent, and then after all this period before puberty, excuse me, with anxiety, they develop depression when they become adolescents. So to identify anxiety disorders in children and to treat them is a way also as a child psychiatrist. So we're talking about a category of conditions divided in different current nosology. Another one is social anxiety, then there is generalized anxiety disorders. These three conditions oftentimes also has or will develop social anxiety or generalized anxiety. So they're not really very distinct because there is a lot of overlap. And that's why clinical studies for treatment, they usually include patients who have all these conditions. Separate from that, there is panic disorder with agoraphobia or without agoraphobia, and then the specific phobias that were also called simple phobias in the past. We'll focus in particular on the first three conditions because most of the information from research was developed focusing on these three disorders: separation anxiety, social anxiety, and generalized anxiety disorders. Anxiety disorder, from a genetic point of view, share a lot of common genes with a mood disorder, with depression in particular. In this slide, you can see that anxiety disorder are connected with, you see anxiety disorder here on the right, are connected with major depressive disorder from a genetic point of view. And this is a strong link, stronger than any other connection that anxiety may have with ADHD, for instance, which exists, but is less strong than with depression or with other conditions like autism or anorexia nervosa. So even in this respect, we need to consider the continuity that from a developmental psychopathology there is between anxiety and depression. The main approach to anxiety disorder is not medication, is psychotherapy, in particular cognitive behavioral therapies. So I don't want to go into this in details because it is not the focus of this talk, but I need to emphasize that exposure and response prevention, which are the active ingredient of cognitive behavioral therapy, are the main approach to anxiety disorder in children. As they are in adults, but in particular in children. Because of a learning component, these therapies have the value of teaching these children how to manage anxiety, not only at that present time, but also give them skills of how to manage anxiety in the future. So they get both a therapeutic treatment value and a preventive value, because different from medication, they are based on learning principles. The pharmacotherapy can be useful and has been shown to be useful. And the group of medication that has demonstrated efficacy compared with different type of controls, in particular placebo, are the so-called antidepressants, in particular the serotonin reuptake inhibitors, and also the serotonin and norepinephrine reuptake inhibitors. So these two main approaches, cognitive behavioral therapy and pharmacotherapy, can also be combined. And there are some data indicating that combined treatment tend to be more effective than a pharmacotherapy alone. So one could use pharmacotherapy, but it's a good thing to combine that with cognitive behavioral therapy. Again, the cognitive component, psychoeducation, cognitive restructuring, acceptance of situation and emotion, from a cognitive point of view, is the component of psychotherapy that has been shown to be effective. And the other component is the behavioral gradual exposure with response prevention. I don't go into the details of this. If you have questions, we can also talk about these issues, but these are a starting point for management of anxiety. If we go to medication, as I mentioned, there is evidence that the so-called antidepressants are effective in relieving anxiety in children with an effect size. You see a G versus placebo of 0.56 as a mean, with a confidence interval that goes between 0.4 and 0.7. So fairly convincing and statistically significant. This is a medium effect size, which translates basically on a number needed to treat very favorable, about 3 or 4, which is better actually than the effect size that we have in depression. So it's sort of a paradox to say the antidepressants are more effective in anxiety than in depression. They should be called anti-anxiety, but they're called antidepressants because they were introduced into medicine for the treatment of depression. And then it was found that actually they worked quite well for the management also of anxiety. The other part of the slide, the second part, indicates that the placebo response is high in anxiety conditions, but is less than in depression. In depression, the placebo response is stronger. And that can be a factor in interpreting clinical trials where in depression we have to contend with a much higher response to placebo than in anxiety. Okay, we can skip this. That indicates basically what I just said, showing that a number of studies were done both in selective serotonin reuptake inhibitors and also in serotonin and norepinephrine reuptake inhibitors. Okay. This slide indicates that, again, compared with depressive disorder, the response to placebo is lower. You see that the placebo, which is the column, the bar, the lighter bar is less in anxiety disorder compared with the depressive disorders. The number to treat is roughly 3, which is very favorable. I remember the number needed to treat is the number, it's a measure of efficacy of a treatment. is the number of patients that we need to treat, the minimum number of patients we need to treat to have one patient more that will respond because of the treatment as compared to the placebo. So if we treat 3 patients, one of them will improve because of a medication. The other 2 because of a placebo effect. Again, you know, it's considered to be favorable because in depression is much worse. In these clinical trials that was conducted with the coordination of an IMH, and that was published in 2008 in the New England Journal of Medicine, 4 different conditions were compared. One was placebo, the second was medication, which is sertraline in this particular case, sertraline, which is an SSRI, serotonin reuptake inhibitor, then cognitive behavioral therapy, and the third was a combination of the 2. This was a randomized study that included almost 500 children and adolescents from 7 to 17 years of age. And the slides reports as a summary the percentage of patients who were improved significantly. You know, they were clinically improved, definitely improved after 3 months of treatment. And you can see that the response to placebo was about 24%, and both sertraline and cognitive behavioral therapy were effective, certainly for about half, maybe more, 60% of the patients. And the combination was the most effective treatment for 80% of the patients. What you can see here, there is still a 20% roughly of the patients who did not improve. So medications are effective, cognitive behavioral therapy is effective, but there are still patients who don't respond, and this is about 20%, which is significant because it's about 1 patient out of 5. So 1 child out of 5 children with anxiety disorder will not improve even with the most effective treatment. This means that we need to improve and to develop better treatment if we can, or treatment for these children who don't respond to the current treatments that are available. The treatment was shown to decrease all the symptoms of anxiety, and in particular, the psychological distress, avoidance. So from a behavioral point of view, the children are functioning better. And certainly, there is a clear impact on their functioning that was demonstrated in these controlled trials. However, after 4 years, you know, one of the good things that we did at NIMH was to follow up these patients, not to let them go, but to make any effort to check back with them even years after the completion of the study. And in this particular study, Dr. Ginsberg, who was one of the investigators, checked back with as many patients as she could 4 years after the completion of the study. And she found that only 22% were on stable remission, meaning they had reached remission from their anxiety and they were still in remission 4 years later. That 1 patient out of 5. And almost half had reached remission, but then they had a relapse. So this is not totally surprising, right? And you know, we see all the time patients who suffer from anxiety, and they get better with treatment, but then later on, they have a relapse. They become anxious again, and this may be due to different reasons. Probably to the fact that they have some risk factors, some temperament, some personality characteristics that increase the risk for them to have high sensitivity to stress. And therefore, they react to stress of life with symptoms of anxiety. Okay. Let's talk about safety now, tolerability, okay? There was this study that was published a few years ago that summarized what we can say about the safety of this medication when we treat for children with anxiety or with obsessive-compulsive disorder. This analysis included anxiety and obsessive-compulsive disorder, which are different conditions, obviously, but this is useful. If you look at this slide, you can see that the dots that have different colors indicate different adverse events. On the right of the slide, you can see suicidality, sedation, nausea, insomnia, headache, and so forth, right? And now the dots indicate the mean from all these studies, about 2,000 patients. And the line indicate the confidence interval. The confidence interval is very important to interpret the data because if a confidence interval is touching the dotted line, that means probably that is not statistically significant, okay? So if you look at the middle column, which basically shows the safety of serotonin reuptake inhibitors versus placebo, you see that the adverse events that are clearly distinct and don't touch the dotted line are sedation, insomnia, see? A risk of discontinuation because of adverse event, which is very non-specific in general, and activation. Okay, and on the contrary, the first one, which is suicidality, it has a confidence interval that is very large, and it cannot be dismissed, obviously, so suicidality can be an issue, but is not clearly linked from a statistical point of view. What we can say from this is that giving this antidepressant, there is a chance that the treatment will have to be discontinued because of adverse event. And this is clearly a higher risk than if we give a placebo. So there are adverse events, and there is a risk of discontinuation because of these adverse events, because the child doesn't like the treatment. And the adverse effects that are more frequent are a behavioral activation. The patient, the child, instead of feeling less anxious, become more tense and paradoxically became more nervous and sometimes agitated. And this can be accompanied by insomnia and at times can be accompanied by suicidal ideation and suicidal behavior. So this is sort of a summary of where we are with these agents that are certainly effective, but can also have adverse events. This slide basically gives more details to what I just said. Talking about suicidality, there has been a lot of talking over the years, over the past 20 years, about the possible risk of increasing suicidal risk when we use antidepressants. And in fact, meta-analyses have shown that there is a very small but statistically significant increase when we consider all the conditions together, depression, anxiety, or obsessive-compulsive disorder, and we look at all antidepressants as a category. When we try to look at specific conditions like anxiety disorder or specific medications, I don't know, sertraline or fluoxetine or venlafaxine, then this signal disappears because the sample is too small. So we can conclude only that as a category, antidepressant has the potential in some patients, seldom and infrequently, to increase the risk of suicidal behavior. So we need to be vigilant and to be careful about using these medications. Besides antidepressants, benzodiazepines are at times used to the control of acute anxiety. Now, there is evidence that benzodiazepine can be useful to decrease acute anxiety in the context of medical procedures. For instance, children who are very anxious when they go to the dentist, or very anxious when they need to do some X-rays or magnetic resonance, or anyway procedures in medical settings that increase anxiety. The use of low doses of medication like lorazepam or diazepam can be helpful in controlling this anxiety. Can, not necessarily all the time, but it can. But there is no evidence that benzodiazepine can be useful on a chronic basis to control anxiety disorder. And therefore, we should not use them because they are habit forming. They can cause dependence because benzodiazepine has negative effect on cognition, on attention, on learning. And children who go to school probably don't benefit from receiving a medication like benzodiazepine that can impair learning of new information. In addition, benzodiazepine can cause paradoxical activation in children, especially young children, and especially children with neurodevelopmental disorder and intellectual disability. So instead of calming down, they become agitated. It is not frequent, but it is not rare either. So it can happen, and it does happen in clinical practice, as you probably know. So benzos are not really a treatment for anxiety disorder in the long term. It can be for acute agitation. We use them in the emergency room when the child arrives that is very, very agitated, and therefore the use of lorazepam, for instance, 1 or 2 milligrams orally or even intramuscularly can be useful to control the anxiety. Let's talk about treating children with anxiety disorder in the context of attention deficit hyperactivity disorder, because this is a very common comorbidity. It is estimated that about a third, between a fourth and a third of children with hyperactivity also have an anxiety disorder. And the approach, the treatment approach, is to treat ADHD, to treat hyperactivity first with stimulants, usually like methylphenidate or atomoxetine. And in most cases, as ADHD symptoms improve, also anxiety symptoms improve. We did a study back 20 years ago. It was published, it is the publication by Abikoff et al. In the RAP network. And we found that most children who have this comorbidity, they just improve both in ADHD and anxiety when they're treated with optimal doses of methylphenidate. Use psychosocial intervention for anxiety, adding an SSRI like sertraline, fluoxetine, fluvoxamine is unclear if it is effective. It can be done. So it is not contraindicated. There is no safety problem, but there are no control studies showing that the combination is better than just methylphenidate alone. Managing anxiety can be especially difficult in children who have some conditions like autism spectrum disorder or intellectual disability, or conditions like selective mutism or Tourette disorder. So while we have good treatments, which are fairly effective for children who don't have major neurodevelopmental disorder, when you have a child who has these conditions, anxiety can be very challenging to treat. And many children do not respond to the treatment that currently we have. So I think that one of the priority of research is to develop treatment to manage anxiety in the context of these conditions. In particular, I want to point out that at the moment we don't have medication that have shown efficacy in selective mutism, but as you know, is a sort of, it belongs to the group of anxiety, of social anxiety, but it has some specific features that are very resistant to treatment. And selective mutism is not uncommon, and oftentimes persists and can lead to impairment to the child, and his potential, cognitive potential, is impaired by this condition. And at the moment, unfortunately, both psychotherapy and medication are not quite as effective as they should be. In autism also, anxiety is quite common. And unfortunately, we don't have evidence that medications are effective as a group. Now, this cannot exclude that you can try this kind of medications in individual patients, but there are no clinical studies that have shown superiority of antidepressant or other anti-anxiety medications versus placebo in children with autism. This is a large study that was conducted also with funds from NIMH, and it was published in the JAMA Psychiatry in 2009, and randomized children with autism, 149 children, to citalopram, which is an SSRI, and placebo. And you can see that there is absolutely no difference between medication and placebo after 12 weeks of treatment. So this is sort of a study that showed how this medication, unfortunately, did not improve anxiety. Okay, that's basically is a secondary analysis done by Emily Simonoff on the same databases that confirmed that there was no improvement in anxiety in autism. This is a small study that was published a few years ago by Christopher McDougall at Harvard. And he basically randomized children with autism and anxiety disorder to mirtazapine, which is an antidepressant with sedative properties, and placebo. And there was no difference, statistically significant difference between the two after 10 weeks of treatment. So unfortunately, also this study doesn't support the use of missed medication. There was also a study of guanfacine. Guanfacine, as you know, is an alpha-2 agonist and therefore acts on adrenaline and noradrenaline. And it is effective in the treatment of hyperactivity, also in children with autism. But unfortunately, as shown by this control study, there was no significant difference for symptoms of anxiety. These were children who were about 8 years of age, and they were randomized to a guanfacine or placebo, and there was no difference between the two. There was also a recent study that tried propranolol, which is a beta-2 blocker, also acting therefore on the adrenergic system and for anxiety, and there was no difference compared with placebo. So also this it's a study. This doesn't mean that if you are desperate and you have a single patient, individual patient could need to try, you could try this kind of medications, but there was no support really from a randomized study. There is no evidence base for the use of these medications in autism. So in conclusion, for anxiety disorder in children, antidepressants, serotonergic and noradrenergic medications like fluoxetine, sertraline, citalopram, duloxetine, venlafaxine, especially duloxetine, remain the only pharmacotherapy with proven efficacy. The effect size is not bad. It's a medium effect size. It doesn't work for everyone. Probably there is a third of a patient who don't really improve on this medication. There can be some adverse effect in some patients. Maybe about 2-3% of a patient may develop behavioral activation. They maybe become agitated. They may have insomnia. Some of them may develop some suicidal also behaviors or thoughts. So something to keep in mind. But certainly there is a good evidence also for efficacy. Benzodiazepine and quetiapine, which is also another type of medication belonging to the atypical antipsychotic, are sometimes used off-label, but there is no evidence from controlled trials that are effective. So one can use them basically on clinical wisdom or because you don't have anything else, but there's no evidence really actually that they work. There is certainly a need to develop treatment to manage anxiety in the context of neurodevelopmental disorder like autism and intellectual disability. This basically concludes the part on anxiety disorder, and I would like to move to mood disorders now. So mood disorders basically include the two major categories, depressive disorder and bipolar and related disorders. They're quite different type of conditions. Depressive disorders include unipolar depression, characterized by episodes of depression without mania or hypomania, okay? It can be severe, there can be psychosis, it can be recurrent, or it can be a single episode, so it is very heterogeneous condition. Another condition is persistent chronic depression, so symptoms that are not so acute as the major depression episode, but they are prolonged in time. They last 1 year or longer. And then these other conditions, which is typical only of children, which is disruptive mood dysregulation disorder. This condition was introduced in the psychiatric nosology in 2013 with DSM-5 to include children who have chronic irritability with recurrent episode of temper outburst that become aggressive sometimes. They lose their temper very easily, but they are chronic irritable. They are always in a bad mood. So it's a condition that is currently being investigated because it's a fairly new concept that was introduced into psychiatry. Bipolar, on the contrary, include bipolar 1. To have bipolar 1, one need to have had at least one episode of mania. And bipolar 2, remember, to have at least one episode of hypomania and to have major depression. And then there is cyclothymic disorder. So from all this, we see that depression per se is not a specific condition for depressive disorder because it can be present also in bipolar disorder. It is essential for the diagnosis of unipolar major depression and also for bipolar 2. And it can be present and usually is present also in bipolar 1, but sometimes it is not. On the contrary, mania, per se is specific of bipolar 1, and hypomania is specific of bipolar 2. So this is very important, I think, for us psychiatrists to keep in mind, because when you see a child with depression, not necessarily we need to rush to make a diagnosis of major depressive disorder, because it could be a manifestation, for instance, of bipolar disorder. Okay, the rate actually of conversion from depression to bipolar disorder has been estimated to be over a period of 4 years, about 6%, 5.6%. So basically, when we make a diagnosis of depression, we need to keep in mind that there is a chance that can be estimated to be about 6%, that in 4 years, within a period of 4 years, that child actually will develop a bipolar disorder. And this is why it is particularly important, because the use of antidepressant in a bipolar disorder is contraindicated. It's not a good idea because not only it is not effective, but it can make the condition worse. And so it can destabilize mood. So if we suspect a bipolar disorder, we should not use antidepressant alone. We should use mood stabilizers and maybe later also to add also an antidepressant. So these are not just theoretical considerations, but they have really a clinical impact on our practice. Risk for conversion from unipolar to bipolar are treatment resistance to depression. So if we treat a child, an adolescent with antidepressant, for instance, and we don't have an improvement, we have a treatment resistance, we need to start thinking that maybe behind that, there may be also a condition that is not really a depression, but a bipolar condition. Earlier onset of depression, another risk factor. The higher number of depressive episodes and hospitalization. The presence of transient manic symptoms that can be difficult to identify in children and adolescents, just because their mood is so reactive that sometimes it's difficult to recognize symptoms of mania. And obviously, family history of bipolar disorder. Major depressive disorder, so unipolar depression, has a heritability that is estimated to be 0.4, which means that there is a strong condition, which is a strong familiarity, but also there is also a strong environmental component, because only half of a risk of major depression can be attributed to genetic conditions. The other, more than half, in this case, 48%, is about half is due to environmental non-genetic conditions. It's a condition that is fairly common. 20% of the people will develop depression in their lifetime. The risk is higher in children who have a parent or both parents with depression. So the risk is certainly higher, something to keep in mind. The prevalence of depression in children under age 13 is not particularly high. You can see that is less than 1%. It's much higher, the presence of this mood dysregulation with disruptive behavior, which is characterized by negative mood, irritability, and temper outbursts. Also, we see that under age 13, therefore in prepubertal period, there is no difference between sex. So the risk for males and females to get depression is the same, okay? And there also in this study showed that there was no time effect, meaning there was not increased prevalence of depression over the years in the last 20 years. However, when we go into the puberty, so in children who have older than 12 years of age, we see that the risk of depression increases. And in particularly after age 13, we have a major jump so that the prevalence increase go to 9% and then to 10%. This is the prevalence by age 18, so it's the cumulative, 12 months prevalence at age, at different ages, 15, 17, and 13 here. And the cumulative prevalence is 16% in girls and 8% in boys. So by age 18, we can expect that 16% of girls and 8% of boys will have experienced an episode of depression. So this gives you the picture that depression, fairly infrequent before puberty, becomes really a major issue after puberty, especially in girls. The duration of the episodes is several months. The risk of relapse can be considerable and can reach, in some studies, also the 70% relapse rate in 2 years. Talking about treatments, we have options. Psychotherapy, in particular cognitive behavioral therapy, interpersonal therapy, psychodynamic therapy, are all therapies that have shown to have efficacy in the management of depression in children and especially in adolescents. Pharmacotherapy also has shown efficacy, but you will see the effect size of pharmacotherapy in depression is small. At the moment, we have 2 medications, fluoxetine and escitalopram, that have at least 2 studies shown superiority versus placebo. And they are approved, at least in the United States, for the treatment of children starting age 8 for fluoxetine and age 12 for escitalopram. All the other SSRI and other medications, like agomelatine and some others, they have some studies that have shown efficacy compared with placebo, but they don't have 2 studies. That usually is the standard to declare a treatment efficacious in depression. Psychoeducation and supportive treatment are certainly the first step in the treatment of depression, and they are sufficient for at least 20% of patients who have uncomplicated depression. So when we see a child with this kind of condition, the first step is usually to have a period of at least 1 or 2 weeks of supportive clinical management, which is non-specific, but it is individualized way of supporting the child, the family, and helping them to identify ways of overcoming the situation of depression. If that doesn't work, one can move to cognitive behavioral therapy with cognitive restructuring, behavioral activation to improve functioning and improve mood. And if not, one can use medications. Medications that have an effect size, and you can see G here, of 0.2. This is a small effect size, which means that the number needed to treat is about 10. So which means that you need to treat 10 patients in order to get one that will improve because of the medication. This is not a favorable effect size. So antidepressants are statistically significant as a group compared with placebo, but the difference is very small. And this difference is small in particular because the placebo effect is very high. you can see there is a G of 1.6 basically in depression for the placebo response, which is an effect size pre-post that indicates that the placebo effect is in particular very, very high in depression and is high in children and adolescents compared with adults. In fact, it's also greater in children compared with adolescents. So if we treat children with depression, the response rate to placebo is about 54% on average. And in adolescents, about 45%. They're both very high, but certainly is something to consider. This is a study that, one of the many studies that showed that there is a strong placebo response. This is a randomized study of duloxetine and fluoxetine versus placebo. This is was a fairly large study conducted internationally in 4 countries, 60 sites. And it shows that there is a decrease in symptoms of depression in all conditions. The placebo is the dotted line, and the medication conditions you see are all together, and they're not statistically different from placebo. This is a scenario that repeats in many studies. The TADS was a particular clinical study that was developed by NIMH, National Institute of Mental Health, and that was published in 2004 in JAMA. And this was a study where about more than 400 children were randomized to placebo, cognitive behavioral therapy, fluoxetine, and combination. And we found that at the end of 12 weeks, basically there was this scenario. This is the response rate. The highest was on combination treatment, 71%. Fluoxetine was 61%. Cognitive behavioral therapy, 43%, and placebo, 35%. There are many things that can be said about this study that tried really to answer questions about different treatment modalities. And it had to contend also with difficulties from a methodological point of view of doing this type of studies. Because without going into the details, I want to mention and to share with you that fluoxetine and placebo are 2 conditions that are double-blind. Basically, the patient and the clinician didn't know if they were receiving placebo or fluoxetine, right? But a combination treatment and psychotherapy, which is CBT, they were not blind. And so this may certainly introduce some potential biases. There is no alternative to, I think, to doing this. And so we thought a lot about alternative design. This was the best we could come up. And I think the study is very informative, but certainly there are limitations to keep in mind. So when you compare the 71% of combined to 61% of fluoxetine, you need to keep in mind that 71 was unblinded and 61 was blinded. Anyway, if we look at the functional impairment, the level of functioning during in this particular study at 12 weeks, we found that the combination was also superior to the other conditions in improving functioning. So while this slide is about symptoms, this is about functioning. So certainly combining treatment and medications is a good way not only of controlling symptoms, but also to improve the level of functioning of the patient. And it is what it's currently recommended. These are some antidepressants. You probably know all of them. These are the medications that are used in children, adolescents, starting age 7 usually. Under age 7, we don't really know if these medications are effective or not. In parentheses, we have the dose range. For fluoxetine, we start with 10 milligrams. We can move very gradually, very gradually to a maximum of 40 milligrams in adolescents. The same for sertraline, 50 to start with, and going to up to 150. It is very important, as you probably know, to start very slow at low doses and not to increase the dose too fast, because there can be side effects. And the side effects can be the one we talked about already, which is behavioral activation. Some children, adolescents, they feel activated in a negative way, and they can have anxiety, and they can develop symptoms that come close to a serotonergic syndrome, meaning myoclonic, tremor, insomnia, and so forth. There have been many meta-analyses lately over the years. This one was done on 34 clinical trials, including 14 medications. And of all the medication, only fluoxetine was clearly better than placebo, with an effect size was actually medium effect size. And this was in large part due to the TEDS trial. These are the starting doses for the antidepressants, and the target, and the last column is the maximum dose that one can reach after many weeks, of course, of treatment. This is in adolescents. This was in children, and this is in adolescents. What differentiates these medications in large part is the half-life and the fact they are metabolized by different cytochromes in the liver. So fluoxetine has a half-life that is longer than other medication, is about 4-6 days or half-life, and also has an active metabolite, which means that the steady level in the plasma is reached only after many weeks of treatment. And so that needs to be taken into account, and not to increase the dose too fast, because you cannot reach steady state yet. And if you increase the dose too fast, when you reach steady state, this will be too high. You can get side effects. Fluoxetine is metabolized by cytochrome 2d6, which is subject to polymorphism, genetic polymorphism. So there is about 7% of the population that are poor metabolizers, and they have high level, therefore, of fluoxetine. And there are about 10% probably that are poor, that are fast metabolizers. And so for these patients, the level will be decreased. You can see from the slides, other medications also have different half-lives, and they have different cytochromes that are involved in their metabolism. Common adverse effects include nausea, decreased appetite, diarrhea, headaches, decreased libido, which is more an issue in adults, but can also be in adolescents. And these adverse events oftentimes disappears or attenuates with treatment, but in some cases they can lead to discontinuation. It is estimated that the negative behavioral activation can involve between 2 to 10% of the children and adolescents, based on the studies. The mania induction is less than 2%. the risk of serotonin syndrome is less than 1%. As you know, the risk of serotonin syndrome is something to keep in mind because of the severity of this condition. The first symptoms are anxiety, tremor, tachycardia, anxiety, insomnia, sometimes sweating, hyperreflexia, sometimes fever, and then it becomes really quite problematic, obviously. Something to consider is discontinuation syndrome. If we discontinue this medication after many weeks or months of treatment too suddenly, especially these like medication like sertraline or fluvoxamine, who don't have a very long half-life, we can get into a discontinuation syndrome, but it's not dangerous, but it is unpleasant. And basically includes symptoms like having a flu, feeling unwell, feeling nervous, having muscle weakness, muscle pain, quite unpleasant. Dizziness, fatigue, something that should be avoided by discontinuing medication gradually over times. I'm looking at the clock just to make sure I don't really go too beyond the limits.
Yes, we started a bit later. I think you have another 5 minutes, 5 or 10 minutes.
5 minutes. Okay.
We still have time, it's okay, and we have lots of questions to you, so whenever...
We have a lot of questions?
Yeah,
Okay.
yeah, we have some questions, yes. Yes.
Some questions?
Yes.
Okay. So I mentioned serotonin syndrome. What I probably would like to do, there are so many things we can say about treatment of depression and then of bipolar that we don't have time to go into that. I'd like to mention it to give you maybe some thoughts about some new treatments that are being introduced in depression. They have been introduced particularly in adults, but there are also some implications for adolescents that have to do with the use of ketamine and esketamine that are different type of medications from the one that we have here. Let's see. Yeah, basically, it has long been recognized that the medication treatment for depression are not satisfactory. The effect size is small. It takes a long time for them to work, so you need to wait a couple of weeks, and then the full effect may take several weeks to come out. They don't work for everyone. Actually, there is about 20–30% of patients who do not respond to this kind of medications. In some cases, some patients get worse. So these are medications that can be very frustrating. And even though they are very popular because there is nothing better, people have not been particularly pleased and happy about these meds. SSRI have become popular and can become widely used also because the alternative that was available for years were the old antidepressants, the tricyclics, if you have known them, imipramine or nortriptyline, amitriptyline, that are more toxic, much more toxic than SSRI. And therefore, SSRI were an improvement over these old medications because of their safety, relative safety, but certainly not for their efficacy. So there has been a continuous look for new medications, and in the last few years, it's become a lot of attention has been paid to ketamine and an analog of ketamine, which is called esketamine, and also psilocybin. So these are psychedelics. They fall into the category of psychedelics, meaning of medications that change our sense of consciousness suddenly, very rapidly, and therefore are medications that have a potential of abuse. And in fact, they have been used for recreational purposes. Therefore, the medication, we need to pay special attention when we want to use them for clinical purposes. I mean, medicine has, pharmacology has a long tradition of using substances that are poisons at certain doses, but they can become therapeutic and quite useful if used at the right doses and in the right context. This is true for psychiatry, is true for medicine in general. Digitalis, for instance, can be poisonous, but can also be very effective in cardiology. So we shouldn't have a bias, a priori a bias to use psychedelics because they are psychedelics for therapeutic purposes. But we should certainly approach them with a lot of caution. Ketamine, in particular, it's a substance that has been around medicine a long time because it's used in anesthesia to induce relaxation, even in children, young children. So even under age 5, ketamine is commonly used as part of general anesthesia. So there is a body of information, of data that support the clinical use in children of this agent. Psilocybin is different, but ketamine certainly has been around for a while. So what is ketamine? Ketamine and an analog of ketamine, which is esketamine. Esketamine, the difference between the two basically is that esketamine can be given intranasally. And ketamine, on the contrary, is primarily used intravenously. So the route of administration is different. And the pharmaceutical industry has developed esketamine because it's easier to use in depression. Both medications are non-competitive inhibitors, non-competitive antagonists to a glutamate receptors that is called NMDA. An NMDA is one of the 3 metabotropic glutamatergic receptors in our body. And glutamate, as you know, is the most common neurotransmitter in our brain. Most of our neurons use glutamate to communicate with each other. So all the synapses that we have in the brain are in large part glutamatergic. So certainly glutamate is very, very relevant to the functioning of the brain. And these agents, they are antagonists to the NMDA receptor. We shouldn't interpret the fact that they decrease the activity of glutamatergic transmission in the brain. Actually, it's just the opposite, just to show how complex the situation is. Glutamatergic receptors are present in different neurons, and in particular, the target of ketamine and esketamine are on the glutamatergic receptors that are present on the GABAergic interneurons. The GABAergic interneurons have an inhibitory function for the glutamatergic neurons. And therefore, using ketamine translates into less inhibition of a neurotransmission that is supported by glutamatergic neurons. And therefore, the glutamatergic transmission is enhanced, is increased by using ketamine. So this is sort of paradoxical, but is explained by the biochemistry behind this system, the glutamatergic system. I know the slide is very busy, but it reflects the reality. Our brain is very complex, and the slide is complex because the reality is very complex. But it's illustrating fact that the GABAergic interneurons act an inhibitory function on the presynaptic glutamatergic neuron, and if we decrease their activity through ketamine, we enhance then the transmission of glutamatergic neurons. Okay, there has been some studies. Ketamine was developed as an antidepressant in adults in particular, and actually it was approved. Let me see if it was approved by ESCAP, by FDA as under the name of Spravato. That's the commercial name. Esketamine is, at least in the United States, and but also in Italy, the medication was recently approved by the regulatory agency for treatment-resistant depression and with major depression with suicidal ideation. What is the advantage of ketamine is that it improves mood almost immediately in a matter of hours. Since ketamine is a dissociative agent that induces symptoms of dissociation in the brain, the use of a normal placebo will not be sufficient to have a double-blind condition, because the patients and also the clinician will realize very clearly who is taking medication and who is taking the placebo. Therefore, all the clinical trials I'm aware of have used midazolam, which is a benzodiazepine, as a control. So midazolam, patients are randomized to receive an infusion in this particular study of midazolam or ketamine. And you can see up here in the first plot, upper plot on the left, that the orange bar indicates the symptoms of depression with midazolam. On the contrary, with ketamine, there is a decrease. That is very clear. And this decrease occurred very rapidly after the infusion in a matter of hours. Sometimes patients just feel better after a matter of minutes, 20 minutes, half an hour. And it persists over time, but eventually it has been shown to attenuate and to disappear after about 2 weeks. Therefore, the current recommendation is to use, to have an infusion or an administration of intranasal esketamine repeated over time. And at the same time, to start an antidepressant in order to initiate an antidepressant treatment that will continue over time. So I think this is my last slide. And I think there is a clinical study that was completed also in adolescents. I don't know the results. It may not. Adolescents are sort of different from adults in that respect. So it's possible that the efficacy is not quite as clear as it is in adult. But I wanted to share with you this information, and especially the effort from a research point of view to look for alternative to the current treatment that we have in depression. I think these are the conclusion that means that we need to be alert at what the next research will bring us in the next few years. I thank you for the attention, and certainly I look forward to answering any question that you may have. Thank you.
Є звук в мене? Окей. Я тоді зараз буду зачитувати питання, які ви задавали, і перекладачі будуть мене перекладати. Я пам'ятаю, що треба це робити не швидко, щоб було комфортніше для перекладача. І так, питання перше від пані Катерини Попружук. Якщо можливо задавати питання, цікавлять наступні. Який вік найменшого пацієнта з депресією з вашої практики?
The youngest patient with depression, maybe 6 years of age that I had, yeah.
Ендогенні та екзогенні депресії у дітей, якщо можна, то у відсотковому співвідношенні у різних вікових категоріях дітей.
Yeah, the percentage is very small. It's very small, less than 1% before puberty. I would say in particular is very small, very low under age 7. So I would say that it's very infrequent to have not symptoms of depression, but the full pictures of a major depressive disorder under age 7. But it has been reported. So it exists, but it's less than probably 0.5%. It becomes higher with puberty. So after age 12, then we go to levels that are like 4-6%, that, especially in girls, that are quite significant.
Психофармакотерапія та її негативні віддалені наслідки у дітей.
Sorry, I don't understand the question.
Психофармакотерапія та її негативні віддалені наслідки у дітей, якщо такі є.
Psychopharmacotherapy.
I think long-term negative effects of psychopharmacotherapy.
The drawback, the side effect, the possible. Yeah, certainly. There are possible adverse effects that can be shown. There can be nausea, there can be headache. Usually these are transient. There is about a risk of about 5% up to 10% in some studies of getting a negative behavioral activation. So children will become activated, become more active, but in a negative way, meaning they feel agitated, they feel nervous, they have insomnia, they may have tremor, and this is always a risk that can range as a risk between 2 and 10%. And then there is a 2-3% risk of having suicidal ideation that may occur in these patients.
Пані Віра Дзобас питає, чи застосовують у лікуванні комплекси вітамінів та мікроелементів, що призначають 18% дівчат? Відразу антидепресанти?
No. The first step when we have depression is to have a period of supportive therapy with the family and the child, and to see how it evolves in the first 1-2 weeks. And then to possibly use psychotherapy more specific, like cognitive behavioral therapy, Also psychodynamic therapy one can use based on what is available in that community. And at that point also to consider the use of medications, but not as a first step. And in any case, to try to combine also some sort of psychosocial intervention. Unless there is a deficit, a demonstrated deficit of some vitamins, like a vitamin D, for instance, I do not prescribe as a matter of routine vitamins or other nutritional supplements. There was discussion if supplementation with omega-3 fatty acid was an effective treatment, but that has not shown to be the case. So I don't think it's harmful. And if you, as a clinician, we want maybe to take advantage of a placebo effect that exists each time that you give some medication, some pill to someone, and you don't want to use that type of vitamins, I think that may also be probably acceptable, but certainly there is no evidence that there is an intrinsic pharmacological value in using that vitamin.
Пані Тетяна Шейніна питає, чи є дослідження стосовно використання прегабаліну для лікування тривожних розладів у дітей та підлітків?
What's the name? Guadalin?
Pregabalin. Pregabalin.
Oh, pregabalin. Sorry. Okay. No, as far as I know, there. I'm not sure. I will need to double check. I have to say, I know that is used sometimes, especially in adolescents. But I don't think that it has been shown to be effective in large control studies. It doesn't have an indication that is recognized by a regulatory agency for the treatment of anxiety. I do not exclude that there may be some studies, reported small studies on pregabalin. Yeah.
Пані Марія Кульбіцька спрашивает, чи використовуєте ви для лікування депресії у підлітків тразодон?
Trazodone, yeah. Trazodone is an antidepressant that has been shown to have efficacy in adults. There are no studies supporting the efficacy in children and adolescents. There have been no studies, basically, in children and adolescents, probably because it's an old drug, and therefore there can be no incentive to pursue controlled studies. It's a sort of a sedative medication. It can be useful in some patients who have insomnia, and so use doses like 50 milligram, 100 milligrams at bedtime can be useful. It is not, it doesn't cause dependence, so it's not habit forming. It has some advantages. So I'm just saying that it's a drug that is there and is sometimes used off-label. Off-label means that there is no indication in children. And it may work, but we don't really have evidence based on studies of this.
Татьяна Мавровська спрашивает методы борьбы с серотониновым синдромом.
Well, the first thing is to know that it may occur and to recognize when it occurs, so that one can stop the medication. So serotonergic syndrome can be suspected when there are tremors, hyperreflexia, agitation, tachycardia, sweating that occur with the use of medications. serotonin agents like SSRI, and instead of getting better, it tends to get worse. And the thing to do is to stop the medication. And since some medications have a long half-life, like fluoxetine, these symptoms may persist for quite some time, for a few days. And so one could use medications like benzodiazepine to control the anxiety and the tremor. One, at some point, if there is a full serotonin syndrome, one can use also anti-serotonergic agents like cyproheptadine. Cyproheptadine is a medication that is used for allergy as an antihistaminic, but also has a strong anti-serotonergic effect, and so it can be used for that purpose.
Пані Ольга Жабіцька і пані Катерина Попружук питають дещо сходні запитання, тому одразу два питання. Чи використовують псилоцибін в лікуванні тривожності в аутистів і психоделічно асистовану терапію в стаціонарі?
Medication that you are interested in is what was the name?
Псилоцибін.
Oh, psilocybin. No, psilocybin has been used, as far as I know, for the treatment of depression in adults. There has been some talking and probably some individual cases reported in also in young patients. But no, as far as I know, it has not been used in children and adolescents. It's just an interesting agent that we should know about, just because there are some studies that were done in adults with depression. And as far as I know, for anxiety, it has not been used.
Пані Алла Смот питає, які препарати порекомендуєте при лікуванні тривожності у аутистів?
Well, as I've shown in the talk, there are no medications that have shown to be better than placebo in controlled studies. So we can say that at the moment we don't have a treatment or proven efficacy for treatment of anxiety in autism. However, since we have patients all the time, sometimes we try different medications. So we could use, it depends on the age of the patient, but sometimes we can use low doses of sertraline, low doses of sometimes some sort of fluvoxamine we can use. But we need to be aware that the chances of response are not very high. And so it may work, it may not work. What sometimes is useful is to use low doses of guanfacine, even though the placebo control didn't really show an efficacy. One could use low doses of quetiapine, like 25 milligrams, especially at bedtime. So these are all medication one could use off-label, but they're not supported by controlled studies. By say these are attempts to use the medication that we have, but we should really individualize the treatment and to make the parents aware that what we're trying to do is something that is off-label. So to explain the fact that we don't really have strong evidence based on that, but since we don't have anything better, we can try to do what we can with what we can. Sometimes it works also because patients are so different one from the other that some of them will improve on these medications.
Пані Віра Дзобас питає, що призначають при депресії внаслідок підліткового голодування, пов'язаного з вагою, в основному дівчат, які хочуть гарно виглядати і ретельно обчислюють калорії.
One could use fluoxetine, for instance. Fluoxetine, it depends really on the severity of the eating disorder. If really an eating disorder is an anorexia or not. But fluoxetine, which is it's an antidepressant, is not contraindicated in the context of an eating disorder. And it has been shown actually to be effective in patients who have bulimia. So to use medication like fluoxetine can be useful in case there is also a component of bulimia. So I would use that for the control of things if I need to use a medication.
Let me check. There are a couple of questions in English here, so I will read them in English. Diana Sushko, how is better to treat depression in adolescents with ADHD and comorbid borderline disorder?
I think the first approach, if there is ADHD, is to treat ADHD and to use stimulants like methylphenidate to try to get the maximum improvement on the symptoms of ADHD. A number of patients with ADHD also have irritability, which can be a sign of depression, and irritability tends to improve when the ADHD is treated appropriately with stimulant medication. So that is the first step. Also because stimulants are the most effective treatment that we have, and we want to maximize them. And then if there is a residual of depression, it depends. One could combine with a low dose of an SSRI like fluoxetine, or it depends what is borderline. Borderline means like borderline personality disorder, which means mood dysregulation. There are no really specific medication for that condition, but one could use maybe, sometimes low doses of antipsychotics can be helpful. So it depends on the severity of the condition. So each patient really needs to be carefully evaluated and the treatment personalized. I don't think that there is one direction for everyone.
And another one in English, Victor Zavidnyuk, is the same treatment relevant for children with depression and anxiety due to PTSD?
So the question is if the treatment is the same for children and adolescents with depression or anxiety?
Is the same treatment relevant for children with depression and anxiety due to PTSD?
So PTSD, so it depends. You know, the treatment for PTSD is basically cognitive behavioral therapy, is exposure, right? Is desensitization. The symptoms of PTSD have shown to be responsive to approaches that use desensitization. A different type of methodology that has been introduced, like eye movement. There are different retraining. There are different approaches. So it's a non-pharmacological approach to PTSD. If on top of that there is also a major depression, depressive disorder, one could use the medications and the approaches that are used for all the patients with depressive disorder. Therefore, SSRI like fluoxetine and so forth.
I suggest we take probably, what, 2 more questions because it's already 8:41. So 2 more questions and we then go on. Тоді беремо ще 2 питання і на цьому на сьогодні закінчуємо. Пані Оксана Журавель питає, як довго можна приймати флуоксетин?
There is no limit, obviously, but the rule is if you have a patient who is at the first episode of major depression and took fluoxetine and has improved significantly, is to continue that treatment for at least 6 months from the time that it has really improved. So we talk about remission. Now, remission is defined as a return to the normal mood for at least 2 weeks. And recovery is defined as the return to normal mood for at least 4 weeks. So by the time we reach remission, we can start counting about 6 months. And then after that, as a rule, we could consider gradually decreasing the medication very gradually, and then in a matter maybe of 2-3 months to get off the medication and to see how the patient does. If, however, the patient is at the second episode of depression, has already had 2 episodes of depression, maybe there is also family history of depression, so it's a more complicated and recurrent type of condition. Most recommendations are to continue treatment for at least 1 year and then to reassess and to reevaluate. So these are just general indications. Then each case is different. It depends on the severity, actually, of the condition and also on the preference of the patient. There are some patients that really don't want to continue treatment on the long term, and their family also are against that. And so you need to reach some sort of a compromise with all that. But the rule is that if you improve, not to discontinue too soon, and too soon means within 6 months, but to keep taking it.
І останнє питання на сьогодні. Пані Марія Марончак питає, чи використовується електросудомна терапія у дітей для лікування депресії?
I missed the first part, which?
Електросудомна.
Oh, is it the... Yeah, electroshock therapy has been used. There are no studies, basically, systematic studies done, randomized control studies. So it is considered a treatment and sort of off-label, meaning we use that because of the data that we have in adults. In adults, we know that electroshock therapy is an effective treatment, especially in depression that is very severe and is accompanied by psychosis, and very effective when there is also catatonia, meaning the patient is very withdrawn, unable to talk at that level of psychosis. So I had a few patients who, because nothing else helped, they received electroshock therapy. So it has been reported, it has been proposed, but again, it's something that is very infrequently done and should be done, obviously, with approval of parents, obviously, of patients, and also the ethical committee of the hospital that should be asked. An intermediate treatment we didn't talk about is transcranial magnetic stimulation that was developed especially in adult, as possibly as an alternative to electroshock therapy, meaning to use a magnet to stimulate area of the brain, especially in the prefrontal cortex, and to try to alleviate depression through this non-invasive stimulation. Now, transcranial stimulation was approved as a treatment, even though it's not very, very effective, but there is some evidence of some efficacy in adults. In adolescents, some studies are currently ongoing, and I think it's too early to say if it is really effective or not. It may be an alternative for some patients. Certainly is not as effective as electroshock therapy. ECT is still the most effective treatment. Possibly the second treatment is esketamine or ketamine, and then there are the antidepressants.
Grazie mille, Professor Benedetto.
You're welcome.
Jörg, would you like to say something in the end?
Yes, just to thank you all for attending and thanking Ben for all his excellent talk and his clinical wisdom he shared with us. It's always a pleasure to listen to you, Ben, and thank you all for coming. And I think we can rediscuss the question about anorexia nervosa and depression and whether antidepressants work in very difficult anorexia cases with Professor Herbert Stahlmann, who will join us at the next talk. So thank you very much, and I hope to see you back at our next meeting. Have a good time and stay safe.
Thank you for your feedback.
Thank you.
Дуже дякуємо всім учасникам за те, що ви були з нами сьогодні. Вас було більше, ніж 560 у Zoom. Деякі питають, де передивитись ці відео. Їх всі можна передивитись на YouTube-каналі доктор Булавінова. В нас є ціла папочка з цими відео англійською та українською мовами. І наберіться терпіння про ваші сертифікати. Будь ласка, і уважно читайте, що ми вам пишемо у Zoom-чатику. Ще раз дуже дякуємо професору Йоргу Фегерту за організацію цього вебінару і професору Бенедетто Vitiello за його виступ сьогодні. Дякуємо, що були з нами. Тихої ночі, наскільки це буде можливо сьогодні в Україні. Дякую.